Glaucoma surgery has seen significant innovations over the past 2 decades in the form of modifications to penetrating, non-penetrating, and minimally invasive glaucoma surgery, or MIGS. Trabeculectomy has stood the test of time, remaining the gold standard for over half a century. As a result of steep learning curves and higher costs, newer techniques are often not feasible in the developing world. Moreover, the long-term success of these procedures has not been fully demonstrated. A recent innovation has changed the way that glaucoma surgery can be performed in a multitude of settings. The procedure is known as gonioscopy-assisted transluminal trabeculotomy, or GATT. Developed at the Glaucoma Associates of Texas in Dallas, it is a minimally invasive surgical treatment for the management of open-angle glaucoma. GATT is normally performed using an iTrack microcatheter, which has a lighted probe that allows for optimal visualization of the advancing catheter in the Schlemm's canal. The alternative method, innovated for its low cost, is known as the suture GATT, which is done using a less expensive 5-0 Prolene suture. The pioneers of this procedure, Dr. Grover and Dr. Feldman, acknowledge the immense public health benefit that GATT can have, particularly in the developing world.
The exciting thing about this technology and the technique that we've developed is that we think we can do it in a very cost-effective, inexpensive, safe way to treat people with minimal follow-up, and that doesn't put the patient at risk for a long-term risk for infection, is not wrought with other complications like tube erosions and double vision and other things that we really don't like to see. And we think it actually has a really good chance of success, and we've seen that over the past 3 to 4 years. So this, in my mind, is one of the most exciting things and one of the most exciting technological developments in glaucoma for our patients here in the U.S., but more importantly, for overseas.
The instruments used in the GATT procedure are low temperature cautery, 5-0 Prolene suture, 25 gauge NVR blade, Healon GV, MST forceps, Swan-Jacob Gonia prism, and McPherson's forceps. Our team, assisted by Dr. Grover, performed a few GATT procedures using the 5-0 Prolene suture. The first step of this surgery is to carefully blunt the tip of the 5-0 Prolene suture using low temperature cautery. After making paracentesis, Healon GV is injected into the anterior chamber. The patient's head is then tilted away from the surgeon, and the microscope is tilted towards the surgeon. This facilitates better visualization of angle structures when seen under the Swan-Jacob Gonia prism. The blunted tip of 5-0 Prolene is introduced from the paracentesis inside the anterior chamber. The trabecular meshwork is identified, and using a 25 gauge MVR blade, an incision is made to open the Schlemm's canal. Under gonioscopic visualization, 5-0 Prolene is threaded in the Schlemm's canal using MST forceps. With gentle strokes, the Prolene is pushed inside the Schlemm's canal until the tip appears 270 to 360 degrees from the starting position. The tip of the Prolene is again caught by the forceps, and the Gonia prism is removed. From the paracentesis, the suture is pulled outside of the eye, tearing away the inner wall of Schlemm's canal. Finally, viscoelastic is washed out of the eye using bimanual irrigation aspiration. The anterior chamber is formed with saline, and the blanching of lymphovessels is used to confirm the surgery's success. There are a number of advantages to the GATT procedure. First, it does not require incisions in the conjunctiva or the sclera, preserving these tissues if future surgery is needed. While MIGS can be extremely expensive, suture GATT is done at a fraction of the cost. Additionally, GATT allows for reduced follow-up requirements, reduces the long-term risk of infection, and has a lower side effect profile than most invasive procedures. Although the GATT procedure is an advancement in the field of glaucoma surgery, It does not come without some limitations. Learning this technique requires the surgeon to have absolute mastery of intraoperative gonioscopy, ambidexterity, and understanding of angle structures. Currently, our suture gap patients are at the 6-month postoperative time point with well-controlled intraocular pressures. None of the eyes have required any anti-glaucoma medication. To conclude, we feel that with practice and perseverance, GAT can emerge as a promising treatment for primary open-angle glaucoma in the developing world.
Thank you very much. What is the difference between the illuminated and this technique?
So illuminated catheter is not available in India, so we have to get it from outside. So Davinder